I must say that the Canadians have always led the way in neurosurgery. I'd like to honor our Canadian servicemen, including my grandfather and uncle, who have served, and also our patient representatives today who spoke, who embody the same courage and character. Professor Rutger and Sandy, thank you for the privilege of speaking today. I want to sort of have a conversation about various causes of headache, which might not be intuitive. These are all my patients except for one or two. So when I see a patient with a headache, I'm thinking about a lot of things, and we'll go through these. Dr. Millerat showed in 2007 that hypermobility, connective tissue disorders, and Chiari malformations were comorbid conditions. Actually, of the patients I've seen, far more than 13% of Chiaris have a connective tissue disorder. But most EDS patients that I see present with Chiari-like symptoms, but do not have a Chiari. So what's a Chiari headache? It's precipitated by a cough or Valsalva strain, maybe brief, over the face, head, usually in the back of the head. It can last moments to hours or days, and it's accompanied by signs of brainstem, cerebellar, and upper cervical spine dysfunction. So the treatment is a decompression, shown by the arrow, with or without a patch. So here's a young lady. I operated on her at age 18 when I was at Georgetown University. Then 10 years later, she'd been a manager of a medical practice, and she came in with headaches. And I thought, the Chiari seems to have herniated down further. But on the CT scan, there seemed to be a lot of a very subtle swelling of the brain, which then, and the MRI of the cervical spine showed that increased blood flow in the vertebral plexus. And that prompted a MRV of the brain with gadolinium, and we saw, and Dr. Kobe pointed out, the loss of blood flow through the transverse sinus, shown there at the arrows. The MR venogram then showed absence of the flow through the transverse sinus. So there's above no flow, and then after anticoagulation, we see flow through the transverse sinus. And that patient did not need surgery. This patient had a 20-year-old woman with Ehlers-Danlos syndrome, global headache, and she was having increasing leg weakness and then urinary incontinence. And I thought, is this a tethered cord syndrome? And then she developed personality change and memory loss, and we found a sinus thrombosis on the CT angiogram. And we treated her with Lovenox, and she made a very rapid recovery in days. There's another young lady, 25-year-old, a missionary, and she had severe retroorbital headaches, global headaches, dystonic seizures. She was in the ICU. We thought she was not going to survive. We obtained this MRV, which showed a thrombosis of the left transverse sinus. Remember, on these films, left is on your right. And she was treated with Lovenox and went from coma to awake and talking in 2 days and was discharged. So how does blood leave the brain? In the upright posture, it turns out that there's a fairly significant flow down the vertebral plexus, as shown on the upper right. And lying down, there's more flow through the jugular vein, shown lower right. So that's normal on the left. And on the right, you can see that there's a constriction of the jugular vein across the lateral mass of C1 underneath either a calcified stylohyoid ligament or the posterior belly of the digastric muscle. So how common is this jugular vein stenosis? It's actually quite common, and allowing the fact that you don't get a CT angiogram if you're not having any symptoms. But of the people who have a CT angiogram, 1/3 of them have compression of a jugular vein, and 1/6 have severe stenosis, and 9% have collaterals, shown here around the spine. These are the lateral condylar veins. And here's a patient who had bilateral jugular stenosis, and you see these massive plexus veins around the vertebrae. So the patient with a cerebral sinus thrombosis or stenosis often complains of moderately severe headache and pressure, feeling like, quote, my eyeballs are popping out. Hearing changes are less common, but they do have a tinnitus, a ringing in the ears, often pulsatile. The headaches are present upon awakening and may get better with standing up. If there's a superior sagittal sinus thrombosis, that's the sinus across the top of the head, they're more likely to have stroke-like presentations and more severe neurologic deficits. So venous obstruction causes increased intracranial venous pressure, and that may cause intracranial hypertension, increased pressure in the skull, and it probably underlies many cases of idiopathic intracranial hypertension. So what is that? The old name is pseudotumor cerebri, because these patients presented as though they had a tumor. To make this diagnosis, you have to rule out the presence of a tumor or other mass lesion, to rule out hypertensive encephalopathy. 20 years ago, they were talking about the causes of obesity, hypervitaminosis, pregnancy, menstrual irregularities, Addison's disease, oral contraceptives, and so on. But it looks like obstruction of venous outflow might be the more important cause. So intracranial hypertension usually affects people in the third and fourth decades, women more than men. Headache, 94%. Most patients have visual obscurations, pulse synchronous tinnitus or whooshing noise, retroorbital pain, double vision, visual loss in 1/3. They have normal radiological studies. If you do a lumbar puncture, the pressure has to be greater than 20 centimeters of water in a lean person, or 25 for an obese patient. And the CSF has to have normal composition. You can't have inflammatory cells that would suggest an inflammatory type process. So the treatment typically has been weight loss, drugs to decrease CSF production, serial lumbar punctures, CSF diversion with a lumboperitoneal or ventricular peritoneal shunt, optic nerve fenestration sometimes for optic nerve compression. Subtemporal decompression has been put forward. I've never seen it used for this problem. Stenting and anticoagulation are used more frequently today. So here's the stenting of a transverse sinus on the left and the jugular vein on the right, and you see that stent in the jugular vein. What about arterial causes of headache? So this was a patient, not my patient, who became blind, ophthalmoplegic, afferent pupillary defect. The eye was protruding out, there's conjunctival swelling, and the neurologist recognized that there must be a problem and got an MRI which showed this fistula between the carotid artery and the vein, the cavernous sinus. That was in a patient with vascular type EDS. That's a fairly rare condition, but more often we see vertebral artery dissection. And if you look at what is the right vertebral artery shown on the left, there's no flow on the right side, and there is flow on the other side. And that's typically occurs after blunt trauma, manipulation, and more commonly in the hypermobile population. It's followed by a suboccipital headache, altered vision, sometimes dysarthria, impaired coordination, stroke-like symptoms. But the most common thing is the headache in the back of the head on that side. Here's a young lady whose circulation for the left side of the brain came from the right carotid through an anomalous artery through the pituitary fossa. Notice also that the transverse sinus is missing on the left side. Another young lady, 35-year-old woman, had a 20-year history of bifrontal headaches and throwing up. And overnight, her headache became extremely severe. It came on after massaging her sternocleidomastoid muscles. She came to the ER. I examined her. She had a very slight weakness on the right side. I wasn't sure that it was real. The brain CT was normal, and so I obtained a CT scan with contrast and then an MRA to confirm my findings. And Dr. Kirby and I found these bilateral carotid dissections. So she's not getting flow through either carotid artery, and it's a miracle that she survived. And she is neurologically intact. So here we are back at Chiari, and another pitfall is assuming too little. So here's a Chiari. It's compressing the brainstem. There's a syringomyelia lower in the spinal cord. So is that the cause of headache? As I mentioned, the standard treatments are decompression. But if you follow these patients over time, 20 to even up to 50% have a return of their symptoms. So there's obviously more to it than the Chiari. In Kleecamp's series of 45 revision decompressions, 1/5 had to undergo a fusion stabilization, and this was because of instability. And he made the point, if functional studies in flexion extension demonstrate hypermobility of the cranio-cervical junction, then decompression should be combined with the appropriate fusion. So many have noted the comorbid conditions of Chiari and EDS, including Millerat, and then Marco Castori showed that chronic headache was a constant feature of EDS, and Jacome said that Chiari malformations were more likely to be symptomatic in the EDS population, and he felt this was a consequence of the occipito-atlantoaxial instability. And that's not surprising when you recognize that the major stabilizing structures between the cranium and the spine are ligaments, as pointed out by Brockmeyer, who discussed the importance of the condylar, the tectorial, and the alar ligaments in holding the skull to the spine. So Gohl said that instability at the cranio-cervical junction results in neurological injury, and that leads to decreased neuromuscular control at the cranio-cervical junction, and then progressive instability. And this pathophysiological process is made worse with malnutrition, vitamin deficiencies, deconditioning, the things that happen in our EDS patients. And many authors, including many who have been mentioned today, have noted the presence of quadriparesis, clumsiness, headaches, suggesting a CNS primary involvement in EDS. Van de Pape showed in EDS the compression of the brainstem by a kyphotic clivoaxial angle. And Doug Brockmeyer, in his series of 101 patients, showed that 1/5 had to undergo cranio-cervical fusion stabilization for a kyphotic clivoaxial angle or basilar invagination or complex Chiari that had been not diagnosed the first time around. So here we have 3 cases of brainstem compression due to ligamentous laxity. On the left, that's a rheumatoid arthritis patient with the odontoids compressing the pons, the brainstem. The second, compression of the brainstem over the kyphotic clivoaxial angle. The third, a cranio-cervical instability with ventral brainstem compression. When does ligamentous laxity due to hypermobility become pathological? So I had a consensus statement with 18 different universities in 2013. We determined that there were 3 additional radiological metrics that helped a lot with the hypermobile population in particular, and we'll look at those briefly. The clivoaxial angle is that angle between the skull base, the clivus, and the back of the odontoid, the posterior axial line. And that angle should normally be 150 degrees, more or less. When it is less than 135 degrees, you're getting into the pathological realm. So here's a very angled clivoaxial angle, very kyphotic, and you see the medullary kinking of the brainstem. The Grab-Oaks measurement is that measurement from the dura to a line drawn between the basion and the posterior inferior C2 body. And if that's more than 9 millimeters, then you have a high risk for ventral brainstem compression. And the Harris measurement was taken from 400 normal subjects, and Harris found that none of them had a distance from the skull base to the spine of 12 millimeters or more. So if that distance is more than 12, then you've got cranio-cervical instability. Now, furthermore, the skull base should pivot over the top of the odontoid between flexion and extension. It should not migrate. It has to pivot over the top. And that's been reported many times. And so here's an EDS patient where in flexion, the skull moves forward approximately 5 or 6 millimeters and then slides back again on extension. And here's a very unstable patient with EDS, and you can see that the skull base is 15 millimeters anterior to the posterior axial line. So that's unstable. Now, without a flexion extension MRI, you might miss this. And I suppose in some circumstances, a CT scan, sometimes I use a flexion extension CT scan. So on the left, that cranio-cervical junction shows a little bit of ventral brainstem compression, but it doesn't look too bad. But on the right, with flexion, you can see a kinking of the brainstem, and that's clearly pathological on a flexion view. How do these patients present? In terms of headache, 100% have headache in the back of the head, the suboccipital region. 70% have neck pain. Pain often radiates to all parts of the skull. It's described as throbbing, shooting, stabbing, sharp. What's the effect of reduction, fusion, and stabilization? If we eliminate the kyphotic clivoaxial angle and the instability, does that take all the pain away? No. It substantially decreases the pain and many of the neurologic deficits. Takes the pain from about an 8 down to a 4, and that's highly significant, but it does not eliminate all of the headache. It substantially improves it, and the same with neck pain. There are other genetic disorders. This is a HOXD3 homeotic transformation, which is simply a gene deletion so that the C1 vertebrae, instead of separating from the skull, remains fused with the skull, which causes a proclivity to instability between C1 and C2. But this young man he was an EDS patient. He's a French horn player, but he couldn't blow the horn hard enough anymore. He also had this MRI shown on the left with this big Chiari malformation. So he came to me with the Chiari, and I obtained the CT scan and found that he had this HOXD3. And you can see the C1 vertebrae fused to the skull base in the far right. Now, I would have anticipated that he needed a fusion, but at this time, he really needed a decompression, which I performed. And 1 year later, he's doing very well without having had the fusion. And there's his MRI. So the radiological metrics that I've presented are guidelines and not rules. And they're not in of themselves indications for surgery. And as Dr. Kobe pointed out, the surgery should only proceed in the right context of the symptoms, the neurological findings, severe pain, the right radiological findings, and then failure of the non-operative treatments. So the next pitfall is assuming that all headaches come from the head. A lot come from the neck. Dr. Long, the chairman at Hopkins, said that 25% of his Chiari patients had continued pain after surgery, and he ascribed this to neck problems. And he wanted to emphasize the importance of mechanical instability in the cervical spine. So others have written about cervicogenic headaches. They point out that 2/3 of the population have headaches, half of which are misdiagnosed. About 2 to 4% have headaches arising in the neck, and these patients have the higher quality of life burden. So here's a C1-2 instability, similar to that shown by Dr. Kobe a few minutes ago. And this is due to weakness of the alar ligaments that allow too much rotation. And they've been described many times in the connective tissue population. The average rotation between C1 and C2 in the adult is about 32 degrees. It's more in children. It's very hard to make this diagnosis in children because they have a lot more movement. Dvorak showed that if the C1 rotates more than 8 degrees in one direction than the other, that implies an alar ligament incompetence. And you might start looking for instability. So upper right, you see the C1 level, and there's a blue line drawn along the direction of the C1 vertebrae. And to the left and there's a yellow line drawn along the direction of the C2 vertebrae. And so if the angle between these vertebrae gets up to 45 degrees, there's no flow through the vertebral artery. And some, like Dr. Kobe, believe if you get up to 42 degrees, you're already substantially compromising the flow through the vertebral artery. Now, at the lower left, you see that the facets at C1-2, that the overlap there is less than 20%. Fielding said that less than 20% facet overlap is an indicator of C1-2 instability. So here's an axial view on the left showing the odontoid is eccentric to one side. That suggests an alar ligament instability. So I make the diagnosis based on headache, mostly occipital, history of presyncope or syncope, blackouts, nausea, brainstem symptoms, severe tenderness over C1 on the back of the neck, spastic reflexes, hypoesthesia to pinprick. They'll feel the pin and they'll know it's sharp, but it doesn't hurt. And then the radiological findings. And the CT scan, lower right, I order a supine CT scan. It's a patient lying on his back, occiput to C1, C2. We don't need the entire C-spine. Neck rotated fully to the left, 90 degrees, and then you scan him with the head rotated to the right. Others have reported on atlantoaxial instability. Goal showed his type 3, and 1/4 of his patients had normal facet alignment, but vertical instability. Interestingly, the picture he showed in the manuscript is another Hox D3 homeotic transposition. And then Yin and Zhu also show a misshapen facet joint that allows a posterior slippage of C1 on C2. Here's a incomplete posterior C1 ring that increases the instability of C1. Professor Francis Smith in England done some beautiful MRI images. Upper left, you see that black ring. That's the transverse odontoid ligament. And then upper right, you see that ligament is missing, a very unstable condition. And upper left, you see the normal alar ligaments. They're black here. And upper right, you'll see that ligament is almost missing. That's a high-grade alar ligament incompetence and atlantoaxial instability. We treat it with some bone between C1 and C2, some screws, and that is generally a good way to do it. The Kimberley anomaly is calcification of a ring around the vertebral artery. Now that is quite common, occurs in 14% of the population, but in some patients it can cause deafness, dizziness, drop attacks, paresthesias, and even a dissection of the vertebral artery. This is a young lady who was in the hospital for weeks, and we thought she had intracranial hypertension. She had headaches, memory difficulties, difficulty walking. And the MRI shown on the left looked, except for the degenerative discs, obviously low chondroitin sulfates and elevated heparan sulfates causing the black disc. Unfortunately, Dr. Irwin wasn't there to fix it, but we sent her out for a flexion extension upright MRI by ambulance to an outpatient facility. And then we saw this dissection, we saw this compression of the spinal cord. So she had headaches, interscapular burning, intermittent breathing issues, altered vision, difficulty with accommodation, decreased sensation over the shoulders, and she had this subluxation causing cord compression, and she had a simple anterior cervical ischectomy fusion plating, and she was out of there in 2 days. So this is a paper by Shadid and Benzel at Cleveland Clinic, and they talk about physiological tethering of the cord. Normal spine on the relatively normal looking neck on the left, but on the right, with the flexion of the spine, there's a stretching of the spinal cord, and they describe a tethering via the sagittal bowstring effect. So White and Punjabi published a number of predictors of cervical instability. So the presence of a positive traction sign, angulation, inflection, extension greater than 20 degrees that Dr. Kobe spoke about, more than 11 degrees in either flexion or extension, and a subluxation of more than 3.5 millimeters, and the presence of spinal cord injury. These are all predictors of instability. Now, headaches may arise from neurogenic pain due to sensitization of the nerve. The neurologic exam can be completely normal, but there is severe pain, and emblematic of this is occipital neuralgia. That's due to sensitization of the occipital nerve. Or it can be a lesser occipital neuralgia or a third occipital neuralgia, for instance. And these are provoked by palpation, flexion extension of the neck. So there's the occipital nerve. It primarily arises from C2, and there's a small slip from the C3 dorsal root as well. These patients have chronic upper neck, posterior head pain, radiates behind the eyes. It can be very severe, like a 9 out of 10. It's sharp, shooting, shocking, stabbing, but they're neurologically intact. There may be some other symptoms like slurred speech imbalance, but they're relatively minor. The diagnosis is by history and a nerve block that can be done in the office over the C2 root. And then the treatment, there are a number of treatments, but the diagnosis, you have to make the diagnosis before you treat it. Now, migraine headaches are 3 times more common with EDS. They're more common in women than men in general, and they're much more common in EDS as well. And I've had a number of patients with severe migraines and sent them for an echocardiogram with bubble technique to look for a hole in the heart, because a little platelet thrombi can go from the right heart through the hole into the left heart, go up to the brain and cause transient ischemic attacks and headaches. And so this is an echo showing bubbles passing through the patent foramen valley. Other causes of migraine include temporomandibular joint dysfunction that Dr. Mitakakis will be talking about, and corneal and retinal conditions, and eye strain, asthenopia, and so on. There can be remote causes of headaches, like these 2 patients had myxopapillary ependymomas, and the traction on the spinal cord caused headache. But we also see other types of tethered cord. This patient with a tethering at T2, every time he bent his head forward, he'd have a pulling sensation on the back of his head and severe headaches. So they worsen with traction signs, straight leg raising, neck flexion, moderately severe pain. We see that also with tethered cord syndrome, shown here, and it may be radiologically occult. So tethered cord syndrome is diagnosed with lumbosacral pain, weakness and sensory loss, bowel and bladder dysfunction, and a positive and a urodynamic confirmation of neurogenic bladder. A pronem riser, often useful in demonstrating tethering or pulling of the conus, the lower part of the spinal cord posteriorly. And the Canadian neurosurgeon, Dr. Hoffman, Professor Hoffman, said, authors of this paper by Jerry Oakes in 1993, authors have demonstrated that patients with the traditional clinical findings of a tethered cord can have a conus in a normal position. TMJ dysfunction, and again, Dr. Medikaitis will be talking about this tomorrow, but I see this so commonly in my patients, and it's due to loss of the disc in the TMJ. Dr. Irwin, need to look at that. It refers pain to the subocciput, the temporalis muscle, and above the eyes, also the levator scapulae, and things I learned from Dr. Medikaitis that can cause shoulder pain and pain in the back of the neck. Pain can be severe, wakes up the patient in the middle of the night, often gets better with Valium, can cause sleep apnea, weakness of the arms even. Disorders of immunity, we had a phenomenal lecture by Dr. Afrin, who discussed the importance of mast cell activation syndrome. So I see this in about more than a third of my patients. It presents with headache, brain fog, nasal-ocular congestion, GERDs, dysphagia, difficulty swallowing, breathing difficulties, but not asthma, GI problems, irritable bowel syndrome, painful bladder, that's cystitis, myalgias, and then, of course, all the cutaneous findings of flushing and pruritus, urticaria, and the anaphylactic type of reactions. They have multiple allergies to food and drugs. Mast cell, very common in the EDS population. Immune problems. I'm treating a patient now with PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. And I usually make a presumptive diagnosis, then send them to a neurologist who specializes in that, orders the special tests. Right now we're just doing a plasmapheresis on the patient, which is the treatment after you treat the strep infection. We've also had patients with neuropochettes, an inflammatory condition affecting the brain. You're diagnosed with history and abnormal CSF, and a couple of patients with paraneoplastic limbic encephalopathy. These are the antibodies to receptors in the brain. So you can have a virus or bacteria, or more commonly tumors, and the antibodies to those things then attack the brain and cause the brain on fire, and they can cause movement disorders, headache, memory changes, and so on. Now, emblematic of this disorder is the anti-N-methyl-D-aspartate receptor antibody receptor encephalitis, potentially lethal, more often in women. They can have behavioral personality changes, seizures, mood disorders. I know this sounds like most women, but sleep disturbances, hallucinations, short-term memory loss. What? EEG showing focal slowing or epileptiform activity. And you can see the changes on the PET scan in yellow and orange there. So these are antibodies against limbic structures in particular and temporal lobes. So headache is a useful measure of disability and suffering, but highly variable and nonspecific. Because these diagnoses are not obvious or intuitive, you have to think about them in order to make the diagnosis. Awareness of the many comorbid conditions of EDS is important to establish the origin of the headache. Ligamentous laxity appears to be an important feature in many of the conditions that generate these headaches. I'd like to thank my co-workers, Claire Francomano, Miles Kobe, Peter Rowe, Rodney Graham, Ellen Pasinke, Petra Klinge, Ed Benzel, Michael Luciano, Mark Alexander, Jonah Murdoch, Jessica Adcock, Rebecca Tuckman, Joanne Wong, Michael Healy, and David Gordon. Thank you for your attention.